This lecture will cover the pathology of the cervical spine as well as some brief elements related to the examination of the cervical spine. The examination portion we'll be reviewing a lot in class, in lab, but I did want to overview a few important things just to get you prepared. There are lecture outline notes posted on Blackboard as well as a PowerPoint presentation. So you may want to pause for a moment now and pull those items together if you haven't already done that. We'll start by looking at muscle strains and sprains, and I think you're going to notice that there's a lot of parallel pathology that we're going to be covering, parallel to what we covered with the lumbar spine. So some of the areas I'm going to delve into a little bit more if they're more commonly involved in the cervical spine. Other areas I'm not going to cover as much in depth if that material isn't really significantly different than the lumbar spine. So we are going to start with muscle strains and sprains, and I just want to review some of the musculature that you're going to see in the cervical area. Particularly here on the anterior aspect, the anterolateral aspect, this bone up here is called the hyoid bone, and we will be looking at that later when we do the palpation in the physical exam. But this is just kind of a free-floating bone that's up in the upper part of the neck here. And there are a lot of muscles attached to it, and you can see by the names, omohyoid, sternohyoid. There's a superior and an inferior part of the omohyoid. These are a lot of those deep anterior and anterolateral muscles that are in the throat area that contribute a lot to swallowing and speech, but not so much to big gross motor activity movements. So I haven't covered those in kinesiology because they don't particularly contribute to gross motor activity. However, they can certainly be involved with the muscle strain or sprain, particularly in more vigorous trauma like a motor vehicle accident or a whiplash type of injury. So you may well have patients who have pain in these deeper structures that are involved. From the posterior side, of course, these are the muscles you're much more familiar with. So the upper trap is the most superficial. Deep to that, then we would see the levator scapula and the rhomboids. Other muscles coming up here are the deeper neck extensor muscles, the splenius capitis, and then again deep to that, it's a little harder to see it, but you have the rectus capitis muscles. Here's the splenius capitis again. Here's the rectus capitis, oblique capitis, inferior and superior, rectus capitis, posterior major. Lots of small, tiny little muscles that we did not bother, again, to memorize the actions and attachments of them. But they are a lot of the deep little extensor muscles in the neck, and they can definitely be involved with muscle strains and sprains. And so when we talk later about interventions, we'll talk more about how we might target some of those muscles. So these muscles can very commonly be involved in strains and sprains. Falls can be another source of injury to the musculature around the neck. Scalenes, didn't mention those. Let's go back here. Scalenes, of course, on the anterolateral side, anterior and middle and posterior scalenes, and the sternocleidomastoid muscle. So all these muscles, again, some of them you're more familiar with, other are the deeper muscles. They all can be involved with muscle strains and sprains to the cervical spine. We talked a fair amount about arthritis in the lumbar spine, and we're going to continue to talk about it because unfortunately it does affect virtually every joint in the body, every synovial joint at least, or it can. So on the left here you see a nice healthy cervical spine. You can see the well delineated facet joints, nice open intervertebral foramens through which of course the intervertebral nerve, spinal nerve root would pass. With cervical spine, arthritis, degenerative joint disease, which is the involvement of the facet joints, and degenerative disc disease, which is involvement of the intervertebral joint, you can see that we will end up with a lot of bone spurring around here, because as the hyaline cartilage wears down and that pressure is transmitted onto the bone thinks it has to get stronger and to be able to withstand that pressure, and so extra bone grows, and that's where bone spurs or osteophytes can develop. those bone spurs and extra growth and osteophytes can encroach into the intervertebral foramen. We also can see that with degenerative changes of the disc, the intervertebral joint will get smaller. In other words, the bodies will approximate, and again we'll start to see what we call lipping of the vertebra, typical osteophytic growth on the anterior aspects of the bodies of the vertebra. So since the joints are already compressed and the intervertebral foramen is already small, we're going to see that when we talk about treatment, we're going to particularly want to avoid extension in the cervical spine, and we'll talk about how that's a little bit unique. We talked about H&P at great length in the lumbar spine, and it certainly can happen in the cervical spine. Our treatment is quite different, but really the mechanism of injury to the disc can be very similar. Again, it can be repetitive injury over time, resulting in eventual movement of the annulus of the nucleus pushing through the annulus, ultimately impinging on a nerve root, or it could happen with one traumatic type of injury. For our treatment, in the acute phase, we definitely want to be able to try to rest the spine and try to start the healing process in some of those tissues. One of the ways that we can help maintain proper posture in the cervical spine is to use a cervical collar. And this can be very helpful. You see two versions here. On the left, probably not the typical kind of collar you'd see used for an H&P. This might be more typical after a surgical procedure. This is called a Philadelphia collar. Somebody in Philadelphia designed it. But it's made of a really firm plastic, and of course you can see it velcros here. It goes up and immobilizes from the chin down to the top of the sternum. This is probably what you'd see more typical of a collar that you might use even after a soft tissue muscle strain or sprain in the cervical area, or again as with an acute H&P. It just provides enough support, gives the muscles a break, but yet still promotes normal spinal posture, and so we want to rest it, but we don't want to promote any abnormal postures. So this can be a really helpful adjunct. As with any acute injury, we can do passive, active assisted, and active exercise as long as we stay within the pain-free range. And then we can also start to apply isometric resistance to the muscles in the head and the neck as long as we stay within the pain-free limits of the muscle. So what we mean, since it's isometric, is that we only want to put as much force on as the person can withstand within their pain-free limits. And we often do that, of course, for the benefit of increasing circulation through the area, helping to relax the muscle, sometimes through alternate contraction and relaxation that'll promote relaxation. If you're in the modalities course, if we haven't yet, we'll be talking soon about mechanical traction, using that for spinal pathologies. And then later on in this unit, we will be doing cervical stabilization activities. So we've already done lumbar spine stabilization. Now we're going to show how we would do cervical stabilization. And so we would start out with the basic elements of that type of exercise. In the subacute phase, again, we may use modalities, but we can certainly include active exercise. We can progress through our cervical stabilization routine, and we can add some gentle stretching. We can continue with mechanical traction, and whereas in the acute phase, our posture assessment just focused on kind of resting in proper posture, now we're going to look more at posture and body mechanics during more dynamic activities. So helping the person resume some of their normal functional daily activities, but yet still incorporating proper posture and mechanics. And then finally, as we move into chronic treatment, if we still need modalities, certainly we can use them, but our focus is going to be on much more active elements. We definitely would be able to do stretching and more advanced cervical stabilization exercises to promote strength and endurance of those cervical muscles. Again, we could continue with traction that could fall under a modality, and of course we want to reinforce posture and body mechanics. So I think one of the things you'll notice is that when we did the lumbar spine and we treated the herniated disc there, we did passive extension and lateral shifting. those things don't apply at all to the cervical spine. Really different mechanics, because basically we still have a lordosis, but we basically only have the weight of the head, compared to in the lumbar spine where we have the weight of the head, arms, and trunk superimposed on the lumbar spine in addition to the impact of the thoracic spine. So it's very different. We don't see the extension bias, we don't do lateral shifting, any of that kind of stuff. So we'll be addressing this more as we do some lab activities. The next pathology we're going to cover is cervical spinal canal stenosis. And this is just a lateral view. You can see here for a variety of reasons, this looks kind of like a herniated disc. It could be pushing into the spinal canal itself. Stenosis just means, right, to make the area or the hole smaller. So it's pushing back. We could also see this as a result of degenerative joint or degenerative disc disease, intervertebral degeneration of the intervertebral disc could cause a lot of hypergrowth of the bone, which could push into there. Bone spurs could be pushing into the spinal canal. So those are probably the two most common reasons why we see that impingement. Since we are pushing onto the spinal cord, of course we might see anything that can be related to a neurological impairment. So our signs of neurological involvement, of course, could be pain, also sensory changes, muscle weakness. So we could be pushing on sensory nerves or motor nerves within the spinal cord. And then again, because we're in the spinal cord, an increase in the deep tendon reflexes. So I know on your paper it says increase or decrease, but here we only have upper motor neurons. So we're only going to see an increase in deep tendon reflexes. In fact, I'll take that out of your notes. You won't even see it. It'll be magic. As far as treatment's concerned, again, we definitely can use either mechanical traction or manual traction. We'll be talking about manual traction just a little bit today related to our exam of the spine. So I'll show you how to apply that. Certainly promoting a chin tuck with axial extension, and then making sure that we're avoiding head and neck extension, which would tend to impinge or pinch that spinal cord even more. If you look up here in the upper right-hand corner, you see another picture of cervical or central canal stenosis, spinal canal stenosis. We also could have stenosis of another foramen, which is intervertebral foramen stenosis, and that's down here in the lower left. And again, same types of reasons. Very commonly we see this because there's degenerative joint disease of the facet joint, and the hypertrophy of bone that grows around the facet joint as a result can grow into the intervertebral foramen and create that impingement. We tend to see this unilaterally, but that doesn't mean it's limited to that. Often people have arthritis on both sides, though often we'll see it worse on one side than the other. So again, our symptoms would still be the same as far as neurological symptoms, because the problem would be pinching the spinal nerve. So we'd see pain. Sensory changes now would follow a dermatomal pattern. Muscle weakness would be specific to muscles innervated just by that level. And then, of course, we could see an increase in deep tendon reflexes. Or a decrease in deep tendon reflexes, sorry. For our treatment, very similar. We could do some form of traction. We definitely want to promote axial extension and chin tucks. No extension, because as you know, that would close the intervertebral foramen, as would lateral flexion and rotation to that same or that involved side. So we want to avoid those types of activities. So that's going to be a big part of our body mechanic training. Alrighty. Our last pathology then is looking at the facet joint. And I could not find a picture of an actual impingement, but here's a pretty good picture of what the facet joint capsule looks like. So here on the outside, of course, this is a synovial joint, so here's our joint capsule on the outside. And then this more sky blue on the inside is the lining, the synovium. And so what happens with an impingement, as we talked about earlier, is that the lining, the synovium in particular, and often the joint capsule portion as well, get pinched between the two surfaces of the facet joint. Now this happens far more often in the cervical spine than it does in the lumbar spine. And the reason for that is because we have this relatively long neck, and on top of it is sitting this big bulbous head. So that head can get whipped around quickly and kind of snap back, and so the facet joints can be gapped and then come back together real quickly, and during the gapping part they kind of stretch and bring the joint capsule here, and then when they come back too quickly, the joint capsule and the synovium can't get out of the way, and so they end up getting pinched in between there. Sounds very painful. It is very painful. The synovium is highly innervated, becomes very inflamed, and so there's a lot of pain, and usually the area or the segment, the facet joint that's involved, is very tender to palpation, so there's a lot of kind of exquisite point tenderness right over the facet joint. You will be palpating the facet joints on the cervical spine in class during the exam portion, so you'll get a chance to make sure you know where those are. Motion's restricted because, of course, anytime the facet joint surfaces come together during extension, lateral flexion, or rotation, they're going to pinch that tissue that's in there and cause a lot of pain. And so even if the tissue's not pinched anymore, the synovium still remains inflamed, of course, for a while it's healing. And so any motions that compress the facet joint is going to cause a lot of pain. So there's usually a very stereotypical or characteristic pain pattern. And the other thing that's important is that you should not see any neurological symptoms with this. I mean, of course you'll have pain, but we can have pain without neurological involvement. However, we shouldn't see sensory involvement, we shouldn't see motor weakness, and we shouldn't see any involvement of the deep tendon reflexes. So absence of those types of neurological signs would help point us more toward a facet joint problem than an intervertebral foramen problem. Mobilization really is very important for this type of treatment, and then we also would do many of the same things we would do for H&P, which would be to restore posture, and then as we move into the subacute and chronic phases, appropriate stretching, strengthening, and stabilization of the cervical spine muscles. So that brings us to the end of the pathologies. I told you it would be quick because we spent a lot of time going over these pathologies with the lumbar spine. What I want to do now is just do a little bit of a quick overview of some of the elements, highlight some of the things you're going to do in class for physical exam of the cervical spine. So it's starting out with inspection, and we did that with the lumbar spine. We know that we want to first start looking at people, especially when they're performing functional activities. Some of the bony palpations, here's the hyoid bone. So it's easiest when the person's lying down because their neck muscles, of course, are relaxed. And you can see here, some of these pictures are out of Hoppenfeld. That's the green hardcovered book in the lab on the resource shelf. And it's a really helpful resource, and I'll direct you to that if you want more information. But you can palpate the hyoid bone. It's kind of floaty. You can kind of push it side to side pretty easily, and it does line up fairly well with C3. And then the Adam's apple, or your thyroid cartilage, is a little bit below that, and that's about C4, and so that's illustrated here. And then if we look on this little more lateral view with the little x-ray, here's the hyoid bone right here, and here's C1, 2, 3, and then here's the thyroid cartilage, kind of spanning 4 and 5 a little bit. A lot of the other ones you've palpated already, so you'll do that. Facet joints are fairly challenging to palpate initially. It's a lot like palpating the hook of the hamate, because you're palpating kind of a small rounded bone through a fair amount of tissue. So kind of think about that. And remember how when we palpated the hook of the hamate, we kind of went in like a little circular motion. And you can do the same thing. Find the spinous process of the cervical spine, maybe with the person seated, nice and relaxed, leaning with their head forward onto the mat table, so they're in a little bit of flexion. Find the spinous process and then go a little bit lateral on each side, and you can kind of find them. And it's nice to do it bilaterally because then you can kind of tell if you're in the same spot. Soft tissue palpation, again, those are all muscles that you've done before. In addition, I would like you to palpate the carotid pulse. The reason you just do one side at a time is because you don't want to compress or limit blood flow to the brain simultaneously on both sides of the artery. So we'll just do one side at a time. Here's the dermatomes. Just a quick review of that. You are going to be doing a neurological exam for the cervical spine. And so you'll need to know what dermatome goes along with each spinal level from C5 through T1. For some of them, you're going to have muscles, key muscles that are innervated at that level. And then for some of them, you'll have a reflex that would be associated with that level. So C5, I think you remember where that dermatome is. We looked at that, if you're in the modalities class, we looked at that for like when we did TENS, for example. Now you do have to memorize the dermatomes, just so you know. This little chart will help you a little bit. So here's C5, the sensations in the lateral arm, that's the dermatome area. Don't worry about axillary nerve. The two key muscles that are innervated by C5 are the deltoid and biceps, and then there is a deep tendon reflex that we can test on the biceps that would tell us if C5 nerve root was involved. So you can see the same for C6. The two key muscles are, well, actually, I just want you to focus on wrist extension. We'll leave the biceps up with C5. Lateral forearm is where the dermatome is, and then there is a brachioradialis reflex. At C7, there's a triceps reflex, and the triceps are the key muscles. C8 and T1 don't have any associated reflexes, and you can see that for C8, finger flexors, and for T1, I want you to focus more on the palmar and dorsal interosseous, or the intrinsic muscles. And then again, you can look at the dermatome chart for the area of sensory innervation. All right. Some special tests we'll be doing in the cervical spine. Distraction. So this is the manual cervical traction. Is also called distraction. You can do it supine, which is nice again for relaxation. Can also be done sitting. And then you can also do compression. So if you're doing compression, you're trying to increase symptoms. If you're doing some form of distraction, you're trying to relieve those symptoms. And it's a way we can test. Valsalva we've gone through before. It's no different than it was for the lumbar spine. And then this is the Adson test. We'll introduce this here, and then we'll be doing this again with the shoulder. This is going to test if we have impingement of the blood vessels and nerves that are coming out from the cervical spine, going through kind of the neck area and up into the upper extremity. All right, that concludes this little video overview of the pathology and the exam. So we will be continuing the exam elements and other lab activities in class. Thank you.